Welcome to Part 2, Health Promotion and Maintenance. Infections can occur more often in our high-risk populace. Remember, we talked about the very young, very old, or immunocompromised. We as nurses can implement interventions to both prevent and detect infections as early as possible. Chart 23.2 talks about the best practice for safety and quality care for nursing interventions for the patient at risk for infection. We as nurses should really be teaching as we take care of our patients. I always, when I remove a surgical dressing, for instance, say, okay, this, if it does, looks great. It's not red, it's not angry, it's not hot to the touch, it's all closed together, better known as well approximated. But when I'm talking to the patient, I'll say, it's all put together. I need you to look at this incision. If you're not able to look at it, I need one of your caregivers or loved ones to look at it so that you know that this is what it's supposed to look like and how to maintain it looking like that once you go home. Other things that we as nurses can do is make sure that we teach good, proper hygiene to our patients and their caregivers and talk to them about washing their hands, making sure they get proper fluid intake and nutritional intake. But look at that chart. It's got some great information. I think sometimes we as nurses choose to do all of our teaching at discharge, and that's really not the best time. One of the greatest places to do patient education is when you're actually doing the task with the patient. Healthcare-associated infections acquired in an inpatient setting that are not present at admission. There also can be called hospital-acquired infections. Can be from an indigenous source, such as the patient's own flora, or an exogenous source, such as from tubes or implants or from a healthcare worker's hands. These infections tend to occur more often because healthcare workers do not follow basic infection control principles, such as hand hygiene. This is where the infection control department in a hospital comes into play. They help us they help the floor look at trends in surgical acquired infections or healthcare associated infections. They track not only the trends, but they also track the patients to know what type of precautions they need to be on if something specific is needed. So that's where the infection control department helps all the way to the bedside. Methods of infection control and prevention. Our number one way that we as nurses can prevent infection is hand hygiene. And I think that has been drilled into our heads enough that we don't really need to say much more about it. Also, ways that we prevent infection is by disinfecting areas. Disinfection does not kill spores. It decreases disease-causing agents, but it doesn't completely remove them. Sterilization destroys all living organisms and bacterial spores. Standard precautions are the precautions that we take with every patient. We assume that every body fluid or everything that the body excretes is or has the potential to be infectious. Now, this does not apply to sweat. Sometimes patients are placed on special precautions above standard precautions. And I think it's important that we realize that just because someone is on an airborne or droplet precaution, we are still using standard precautions with that patient. We're just adding to them. A patient on airborne precautions. Now remember, we talked about airborne microbes. They're ones that are tiny little particles that can attach to dust and they linger in the air much longer. This is where you see the use of negative pressure rooms, and you also will see the use of N95 masks. Examples of airborne microbes that we need to use airborne precautions for are like TB, measles, and varicella. Now, we talked about earlier, droplet precautions are caused by organisms that are in droplets, and they only can go about 3 feet, and they're not suspended very long. So these patients need to be on droplet precautions, which would include masks, a gown, gloves, face shield, but they don't necessarily require an N95 mask. Contact precautions for patients who have or are suspected to have an infection transmitted by direct contact or contact with the person's items. Staffing and patient placement and cohorting. When you're dealing with a patient who has an infection, you want to make sure that you have adequate staff so that the nurses are able to make sure that they're donning and doffing their PPE correctly, that they're able to keep that patient safe by making sure they have the correct precautions in place. Patient placement is also, and part of staffing is making sure that patient, if at all possible, is in a private room. Now, if they have airborne or droplet, they truly need to be in a private room. That's a non-option. But also, you wouldn't want to assign, if you were the charge nurse for that day, you would not want to assign a patient who has droplet precautions and airborne precautions and someone who is immunocompromised. So that's where cohorting, where they try to keep patients off of infectious patients off of units who have immunocompromised patients, or if they are on the same unit, that perhaps they do not have the same nurse. During the COVID-19 pandemic, most hospitals have been cohorting the patients who are presumptive or who do have COVID-19 onto particular units, and those nurses and staff are taking special precautions when taking care of those patients, such as airborne PPE, wearing the N95 mask, placing the patient in negative pressure rooms. So that's one very current example of cohorting. Multi-drug resistant organisms, infections, and colonizations. MRDOs, microorganisms, have become resistant to certain antibiotics. Some of the most common are MRSA, VRE, and CRE. So let's talk about those. Before we talk about MRSA, let's talk about just plain Staph aureus. Staph aureus is a common bacteria found on both the skin, perineum, and in the nose of many people. It does not usually cause an infection as long as that person is not immunocompromised and has intact barriers such as their skin. Now, in the past 40 years, more Staph aureus infections are not responding to penicillins or methicillin. When I was a kid, if you were sick even a little bit, you got penicillin, and because of that, people have become more resistant, and those microorganisms have become resistant to the penicillin-based drugs. Let's pause here for a moment and talk about community-associated MRSA. This causes infections in healthy, non-hospitalized people. Where you see this is when the MRSA gets into the skin and can cause abscesses, boils, and blisters. The best ways to decrease these incidents from growing problems is about, again, talking about healthy hygiene and keeping those areas clean and covered. Now, just like community-acquired MRSA, hospital-acquired MRSA is spread by direct contact. It invades the hospitalized patient through different tubes, vascular devices, endotracheal tubes, and surgical sites. Healthcare-associated MRSA is not only very costly to the healthcare organizations caring for the patient, but the patients themselves can quickly develop infections in the bloodstream and quickly progress to sepsis and even death. So because of this cost, not only monetary but to human life, we as healthcare workers try to decrease the incident of MRSA in our hospitals and other healthcare organizations. One way we do that is by bathing the patients daily in a chlorhexidine solution to prevent the patient from requiring MRSA if they have indwelling catheters or vascular access devices or endotracheal tubes. So in most hospitals, you'll see most patients in critical care who have one of these devices, especially a central line, bathed in chlorhexidine wipes daily. Now, I already talked a great deal about the community-associated MRSA. Remember that it causes infections in healthy, non-hospitalized patients. But it's important that we talk about hand hygiene and avoiding close contact with people with infectious wounds. And where I've seen this occur is when a caregiver, a family member, is caring for someone who has a wound with MRSA, and they're already at home, and they're caring for them but not using correct hand hygiene when caring for it, and then they develop a boil or a blister that ends up being cultured positive for MRSA. So that's the reason when we're teaching caregivers how to care for our patients that we make sure that we teach them about good hand hygiene. Vancomycin-resistant enterococcus is, of course, resistant to vanc. Risk factors include prolonged hospitalizations, severe illness, abdominal surgeries, enteral feedings, and immunosuppression. VRE can live on surfaces for weeks. CREs are resistant to the carbapenem antibiotics that are given to patients with abdominal infections such as peritonitis. The use of these antibiotics became very widespread over the last 15 years, and just how MRSA became resistant to the penicillins, the peritonitis became resistant to these carbapenem antibiotics. High-risk groups for these include ICU patients, nursing home patients, and immunosuppressed patients. When you, both CRE and VRE, and MRSA for that matter, all of these ways that the hospitals try to prevent these is by giving the chlorhexidine wipes, baths to patients anywhere between 12 and 24 hours daily. I'm going to go ahead and stop part 2 here. I don't know about you guys, but I feel like I need to go wash my hands after talking about all this. So we'll finish up with number 3.